So good evening everyone. In this module of NNF Shine on week 6, we would be discussing about neonatal hypoglycemia, and also the second part of the lecture would be on emergency triage treatment and assessment, otherwise called as ETAT. So all of you know that neonatal hypoglycemia is one of the common transient metabolic problem which happens in newborns, and there may be a lot of underlying causes. So our learning objective would be to learn about the definition of hypoglycemia. We have to identify which neonates are at risk of hypoglycemia. What about the estimation of blood sugar in neonates and management of hypoglycemia? So neonatal hypoglycemia, that is, by and large, is defined as blood sugar less than 45 milligram per liter. But there are various definitions. There is no consensus on it. There are something called as various thresholds which are described. But the common definition for practical purposes for students, it is defined as blood sugar less than 45 milligram per dl. Okay. So most common metabolic disorder, as I earlier told you, it is one of the most common transient metabolic problem observed in neonates.
45 minutes.
So you have to excuse me, please mute yourself, all of you. Rahul Saran, please mute yourself. Dr. Rahul Saran.
I have muted him.
Sorry for
you can continue.
Yeah. Yes. Sorry for the disturbance. So as I told you, it is the most common metabolic disorder, transient metabolic disorder observed in newborns, and you have to anticipate, prevent it, and if you treat it early, you can reduce the mortality and especially the morbidity and the long-term sequelae associated with hypoglycemia. So which babies are at risk of hypoglycemia? So preterms, low birth weight neonates. Okay. Why? Because these babies have a low reserve of glycogen, and hence they are not able to sustain glucose levels if there is no adequate feeding or intravenous fluids. Infant of diabetic mothers, why these babies are at risk of hypoglycemia? Because they have hyperinsulinism. So that is the reason why they are at risk of hypoglycemia. SGA, IUGR babies are at increased risk. Maternal intake of drugs, especially beta blockers, which can inhibit insulin, which can cause hypoglycemia. Neonates requiring IV fluids when there is any disruption of fluid administration, or because of their sickness levels, they are at risk of hypoglycemia. And any sick neonate, which may be perinatal asphyxia, delayed feeding, sepsis, hypothermia, polycythemia, because they are under stress, their requirements vary, and they are at higher risk of hypoglycemia. So frequency of monitoring will vary from the condition to condition. Okay, so in babies who are at risk for hypoglycemia, usually the screening is started by around 2 hours of life, and then it's done at 6, 12, 24, 48, and if required at 72 hours. This is the screening frequency. Why this is time like this is, in studies, it has been found that the lowest blood sugar level occurs after the cord is clamped and the baby is born. The lowest blood sugar level occurs by around 2 hours of life. So if you do blood sugar monitoring earlier, we may miss this lowest nadir which occurs in these babies. That's why it is timed at around 2 hours. But if the baby is symptomatic due to any reason, even before 2 hours, you can do blood sugar monitoring. Okay. So on neonates who are receiving IV fluids, it has to be done every 8th hour early, just to keep the track of what the blood sugar level is. In neonates who are not on IV fluids, you will do it 12th hourly, and if two values are normal, and if they are on a good amount of feeding, we can stop glucose monitoring. So what are the do's while estimating blood glucose? So blood glucose is monitored by heel prick or by a peripheral vein. Okay, so you need not do always peripheral line, but if you are sampling the baby for some other tests which we want to run, At the same time, you can club blood sugar monitoring by doing a venous sample. Okay, you need not resort to heel prick separately when you are doing sampling for some other purpose at the same time. So if there is no, venous sampling being contemplated at that point of time, you can go for heel prick. So heel prick is the commonest method by which you check the blood sugar. So make sure that the heel of the baby is warm, otherwise it is very difficult to get a sample. So if the peripheries are cold, baby is in cold stress for any reason, you need to warm the heels before doing the prick. So asepsis is always important. So you need to prepare the site with 70% alcohol, isopropyl alcohol or spirit, and let the spirit dry, and then prick the posterolateral aspect of the heel. So this is important because you should not prick near the point of the heel. You should prick only on the sides, on the lateral aspect. I will show you in the next picture. And you should always allow a wipe of the first drop which comes out. Then the second drop only you should place it in the glucometer and then read it. So if the blood sugar value is low, you have to always confirm it with the lab sample. Okay, so lab sample is collected in a fluoride vial, and then it is sent to the lab for estimation. Okay, so this picture depicts what are the ideal areas for screening. So on the medial side and the lateral side, that is on either side of the heel, preferably on the lateral aspect. The point of heel has to be left out. You should not do it here because the vascularity is less here, and the tip of the calcaneum is close to the skin. So if you repeatedly prick here, you can you may not get good sample one. Next, you may introduce infection into the heel of the baby, which can even lead to calcaneal osteomyelitis. So choose these two areas which are on the either in the medial side or on the lateral side, which has high vascularity. Okay, so you can grasp the heel like this at the arch and near the ankle and then prick. Okay. So what are the don'ts when you are estimating blood sugar? Heel should not be cold to touch. Avoid pricks in the middle portion of the heel. The reason I explained to you already. You should avoid deep pricks. Okay. So iodine should not be used for skin preparation. It can interfere with blood sugar measurements. Allow the site to dry before prick. That is important. Preferably, you should let the first drop wipe off the first drop also. And lab analysis, if at all, if you find a low blood sugar in this heel prick, you should not delay the lab analysis, because delaying lab analysis may result in fall in plasma sugar by 14 to 18 milligram per DL per hour. Next, we will come to the clinical aspect of hypoglycemia. So in the earlier part, we saw that a baby who is at risk of hypoglycemia, who may not be symptomatic, we wanted to monitor blood sugars, because there are group of babies who can present with asymptomatic hypoglycemia, whom you want to pick up before the symptom develops. But despite this monitoring, okay, some babies may go on to develop hypoglycemias, which is symptomatic, or these babies, some babies may be born outside and then they may come to you with symptoms of hypoglycemia. Or some of the babies, you might have thought that baby is stable and shifted to postnatal ward, and these babies can present with hypoglycemia. So there are, you need to know what are all the signs and symptoms of hypoglycemia so that you can identify it early and you can screen for it and rectify it, treat it if required. Okay. So hypoglycemia can cause symptoms due to two reasons. Okay. The symptoms of hypoglycemia is divided into neuroglycopenic symptoms. That is, due to lack of glucose to the brain, lack of glucose supply to the brain, you develop these neuroglycopenic symptoms, which includes symptoms like lethargy, poor feeding, baby may go into apnea. Okay, so these are all neuroglycopenic symptoms. Okay, and baby can also develop through a seizure. Okay, this is because reduced glucose supply to the brain. The other symptoms are due to the compensatory mechanisms. Okay, when there is hypoglycemia, what body tries to do is to produce other hormones like catecholamines, which in turn will increase the gluconeogenesis and glycogenolysis, and to bring back the sugar levels to normal. Okay, because of these compensatory mechanisms, the catecholamine and other hormones, stress hormones being secreted, baby will exhibit some other symptoms. These symptoms are called as are irritability, jitteriness, okay, so tachycardia, because adrenaline levels are going up, okay, so baby can have sweating, tachycardia, all those things, okay. So symptoms complexes are divided into neuroglycopenic symptoms, which is due to lack of glucose, and the other set of symptoms are due to the presence of counter-regulatory hormones, okay. So, but the symptoms in newborns, all of them, I mean, despite irrespective of the underlying disease, may be mimic, the same. Okay, a baby with sepsis can have whatever symptoms described for hypoglycemia, especially those which were termed as neuroglycopenic symptoms. A baby with hypothermia again can have all kind of symptoms. A baby with perinatal asphyxia can have, even hypocalcemia also can mimic the symptoms of hypoglycemia. Okay, so you need to always interpret the symptoms in the context, okay, of what it could be. And obviously, you can confirm only with bedside point of care blood glucose measurement. Okay, right. So if signs are not alleviated after correction, okay, so you have suspected hypoglycemia. So if for some reason you were not able to measure the blood glucose levels, and if you have given 2 ml per kg of dextrose and the symptoms are not improving, you can always consider other diagnostic possibilities. But nowadays, everywhere we have access to point of care blood sugar measurement. So it is not a problem whenever you suspect hypoglycemia and the blood sugar levels are normal, always you can consider the alternate diagnosis. Okay. So before going into treatment, you should understand what is glucose infusion rate. Glucose infusion rate is the how many milligram per kilogram per minute you are giving glucose. Okay, so that is the called as glucose infusion rate. Okay, so normally babies would require around 4 to 6 milligram per kg per minute. Okay, it will be around 6 milligram per kg per minute. The requirement will be for a preterm baby, and it will be 4 milligram per kg per minute for a term baby. Okay, so in babies with hypoglycemia, we may have to use a higher GAR. Okay, so babies require higher GAR than adults. Adults usually require only 2 to 4 milligram per kg per minute. Okay, so how will we arrive at this glucose infusion rate is, so you have to put in the percentage of dextrose which you are using. For example, if you are using a 10% dextrose fluid, so that you put, and then fluid rate ml per kg per day. So if you are giving 100 ml per kg per day of 10% dextrose, if you divided it by 144, then you will get the GAR in milligram per kg per minute. Okay. So now let us move on to management of hypoglycemia. So hypoglycemia, as we already know, the definition is less than 45 milligram per DL. So if this can be an asymptomatic hypoglycemia or symptomatic hypoglycemia. First, we will see how we will manage asymptomatic hypoglycemia. So this asymptomatic hypoglycemia you would come across in babies who are who are at risk of hypoglycemia, and you are doing a scheduled blood glucose estimations in these babies. Okay, so babies may not be symptomatic at 2 hours. If you check blood sugar may be less than 45, but it may be more than 25. It is more common in babies who are like late preterm babies, IDM babies. Okay, so if the blood glucose single value is more than 25, so you can give measured feeds around 20 to 30 ml. Okay, so after giving feeds, 1 hour later, you can check the blood sugar. So if the blood sugar of the baby rises above this 45, then this baby needs frequent breastfeeding, and glucose should be checked every 6 hours. Okay. If the next value is between 25 and 45, then or the value can be below 25 also. So if the value is below 25 or if the value is below between 25 and 45, what would be the sort of treatment that we will see after looking at what we will do to a symptomatic baby. So who are all these symptomatic babies? Already, as I told you, the baby can have neuroglycopenic symptoms or baby can have symptoms due to the counter-regulatory hormones like catecholamines, right? So when these symptoms are there and blood sugar is less than 45, then you have to give a dextrose bolus to bring back the sugar to the rapidly bring back the sugar to the normal levels and alleviate the symptoms. Okay, so 10% dextrose bolus, 2 ml per kg, you have to give over 1 minute. And then you have to start dextrose infusion at a rate of 6 milligram per kg per minute. Okay. Subsequently, you should check blood sugar after 30 minutes in a symptomatic baby. Okay. So now we will come to the left side of the chart, flow chart. So after in an asymptomatic baby, when the blood sugar was less than 20, blood glucose was more than 25, we have given feeds and then we have checked blood sugar. Blood sugar has not risen to more than 45. In this baby, if the blood sugar is remaining between 25 and 45, you will directly start glucose infusion at 6 GAR because they are asymptomatic. But even if they are asymptomatic, but the sugar level is less than 25, you will give bolus and then start a dextrose infusion. Okay, right. So after starting glucose infusion, you are expected to check sugar in 30 minutes, but after a feed, you can check after 1 hour in an asymptomatic baby. Okay. So after this, if the blood glucose reaches more than 45, you can begin oral feeds and then monitor blood sugar every 6 hours. Okay. So if the blood glucose remains less than 45, you have to increase GAR by 2 milligram per kg per minute. Okay, from 6 to 8, 8 to 10, 10 to 12. And then after each and every change, you will measure blood sugar after 30 minutes. Okay. If the blood glucose is more than 45 milligram per DL for 24 hours, okay, then you can start tapering your GAR by 2 mg per kg per minute every 6 hours. And then you can simultaneously increase the oral feeds and keep monitoring blood sugar. Okay. So if baby is not maintaining blood sugar more than 45 for any reason, even with a GR of more than 12 milligram per kg per minute, then it is called as refractory hypoglycemia. So these babies may require additional measures, which includes administration of steroids. And also in some cases, if we had already done a critical sample and found hyperinsulinemia, then we also use diazoxide in such babies. Okay. Up to up to 12.5% dextrose can be administered through a peripheral line. If the baby is requiring higher GAR and the tonicity is going up, then you have to have a central venous access. That is either through the umbilical vein or peripherally inserted central catheter, also called as PICC line. Through that, we can administer the fluids. Otherwise, more than 12.5% will cause a lot of extravasation injury, and you may not be able to maintain the line for a long time, and it will cause too much of tissue damage. Okay, so we also need to understand what is resistant hypoglycemia and what is prolonged hypoglycemia. So resistant hypoglycemia is the one which is persisting despite increasing GAR to maximum, okay, for more than 12 hours. Prolonged or recurrent hypoglycemia is hypoglycemia which persists beyond 7 days of life. Okay. So when such things are there, it is not a simple hypoglycemia. There may be an underlying endocrine or metabolic problem, uh, coexisting metabolic problem. So what endocrine problem can be there? As I told you, hyperinsulinism can be there, very high insulin levels. There could be other reasons for hyperinsulinism. It may not be simple infant of diabetic mother. There can be an insulin secreting problem in the baby. Like all of you would have heard, nesidioblastosis all those stuff, right? Okay. So it could be hyperinsulinism of that reason, or it can be some other endocrine reasons. Like it can be just primary hypopituitarism. Along with that, other hormones can be low, reduced cortisol, reduced thyroid hormones. All these things can coexist, or it can be a metabolic problem, usually problem. So let me going into the detail of all those stuff. So here in this table, you can, a snapshot view of like, how much, what would be the combination of fluids you need to give to achieve a GAR of 6, 8, and 10 is provided. So at a volume intake of 60 ml per kg, if you give 42 ml per kg of 10% dextrose and 18 ml per kg of 25% dextrose, then you would achieve a GAR of 6. So then this is at 90 ml per kg, 120, 150. So various combinations are given here for different GAR requirements. So this table, if we put up in the unit, we can quickly, it will be a ready reckoner for us to refer to the composition and then start fluids swiftly. Okay. So for babies less than 1,500 gram and more than 1,000 charts are provided. For babies less than 1,500 gram, because we would start at a higher TFR, okay, total fluid requirement. So this different chart is provided, okay. So these babies with the hypoglycemia are at risk of neurodevelopmental sequelae. They can have seizure, developmental delay, cognitive deficit. So they need to be put on a high risk follow-up program, and we need to closely monitor development of these babies. Okay. So these babies may also require, neuroimaging later to identify if there is any delayed development and if you think there could be some other reason for developmental delay, and you want to confirm with you may have to go for an imaging to identify whether the lesions are attributable to hypoglycemic injury or any other coexisting problem is there. Okay. So otherwise, generally, we don't regularly do MRI in all these babies. When we have, when we think as a clinician, there could be some other underlying cause which can attribute to this developmental delay, we may have to do. But these babies need to be on long-term follow-up to identify developmental delay and provide, and we need to advise them early intervention. So the key messages in this part of the lecture is that it's a common problem in preterm low birth weight sick neonates and infant of diabetic mothers. Hypoglycemia can cause brain injury with long-term neurodevelopmental impairment, and they should be screened at regular intervals. And if identified, have to be treated promptly. Early breastfeeding and frequent feeding helps to prevent hypoglycemia. Okay, and we need to follow up these neonates for the neurodevelopmental status. The next part of the lecture would be on emergency triage assessment and treatment. So emergency triage assessment and treatment is important even for neonates. Okay, so triage means sorting. Okay, so why is it important is to avoid procedural delays in initiating emergency treatment, and we need to do rapid screening of neonates who require immediate attention for life-threatening conditions. Okay, so we have to classify which babies will require immediate treatment and which baby you can give some time and then start treatment, and which cases are non-urgent so that you can ask them to come later in OPD or for consultation. So the objectives here would be to understand the process of identification of sick neonates requiring urgent attention and carry out this emergency triage and assessment and treatment of all sick neonates when they arrive at a health facility. So usually Neonates are triaged into these following categories. Okay, you classify them into emergency, priority, and non-urgent. Okay, EP and N. Okay, emergency, priority, and non-urgent. Emergency case requires immediate treatment, emergency treatment. Okay, priority case requires an assessment and a rapid action. So they will give some time for you to assess and then start treatment. Okay. So emergency cases, you have to start treatment immediately. Okay. You will not even have time to ask questions. So you need to start treatment, stabilize the baby, and then you go back and identify the etiology for the presentation. Okay. Non-urgent cases are just they need assessment, counseling, and then follow up on OPD basis. So once emergency signs are identified, you have to stabilize the neonate. After stabilization only, you have to take a detailed history and perform relevant examination and relevant laboratory investigations. After deciding the main diagnosis and any secondary diagnosis, treatment should be started. So treatment always you will be starting with the supportive treatment and then you will go for a specific treatment. For example, you are seeing a baby with in shock. So first would be to treat shock, okay, which may or may not require fluid bolus and inotropes, and then subsequently specific treatment based on if you think it is sepsis, and you will be starting the antibiotics. Okay, so you have to monitor closely for response to treatment. You should look for the endpoints, therapeutic endpoints, what you are looking at, and then on discharge, you should explain mother the danger signs and advise for follow-up. Okay. So what are those emergency signs? When these conditions are present, you classify the baby into the emergency group, triage them into this emergency group, which require immediate treatment. So when there is hypothermia, that is moderate hypothermia or severe hypothermia, when the baby is apneic or baby is breathing with presenting with gasping respiration, or when the baby is having severe respiratory distress, that is rate more than 70, retractions are there, grunt is there, baby is having central cyanosis, baby is having shock with cold peripheries, CFT more than 3 seconds, weak pulse, tachycardia, or when the baby is having convulsions, encephalopathy, or coma. Okay. So action is these babies requires urgent intervention and emergency measures. So you should stabilize the baby and they have to be admitted in the special newborn care unit. So what are those priority signs? So priority babies, as I told you, you can assess and then start treatment. They give some time for you to assess. So here you have a tiny baby, less than 1.8 kg. Okay, temperature between 36.4 and 36.5. That is uh, um, mild hypothermia, mild to and severe cold stress, and some respiratory distress rate more than 60, around 60 to 70 with minimal retractions. Baby is irritable, restless, jittery. Baby is refusing to feed. There is abdominal distension, severe jaundice, that is less than 24 hours with palms and soul stained, or jaundice more than 2 weeks, severe pallor, bleeding from any site, major congenital malformations, TEF, anorectal malformation, meningomyelocele, large baby more than 3.8 kg, or according to percentile chart when they are more than 90th percentile. Okay, so these are all some of the priority cases in the newborn setting. So in priority cases, what are the actions we need to do? We have to do an assessment immediately, need to be attended on priority basis, and also they need admission. But you always can take a history, do a preliminary evaluation, and then assessment. If they need immediate attention, you can initiate treatment, and or after admission into SNCU, you can start treatment. What are non-urgent signs? Non-urgent signs are those babies who present with milder symptoms like jaundice. Jaundice which is not severe, which is not on day one, which is not involving palms and soles. Okay, they are non-urgent signs. When they are presenting with transitional stools, babies can present with transitional stools. What is transitional stool? Usually around 3 to 5 days, they can present with frequent passage of stools. Okay, when they are presenting with developmental peculiarities. Okay, minor birth traumas, paucitic, that is spitting, repeated spitting, regurgitation, superficial infections like pustules, minor malformations, all cases which are not categorized as emergency or priority will fall under this non-urgent signs. Here you need to reassure the mother and send her. So again, in this table, a quick summary of what are all the conditions which we have described as emergency signs and what we are supposed to do. Okay, so a quick recap: hypothermia, apnea, gasping respiration, severe respiratory distress, central cyanosis, shock, coma, convulsion, or encephalopathy. Here they are at, these babies are at high risk and they require emergency intervention. And after stabilization, you will shift to NICU. So here you have a priority are those less than 1.8 kg, temperature between 36.4 and 35.5, respiratory distress, not amounting to emergency, refusal to feed, abdominal distension, severe jaundice, severe pallor, bleeding from any side, but there is no shock. Okay, bleeding with shock will come as emergency. Okay, congenital malformations like TEF, meningo, ARM, and large baby. Okay, so here you need to do a quick assessment and then you have to attend them on a priority basis and they will need admission. Okay, they may not need immediate starting treatment in the ER. Non-urgent cases, which we have already described. So you have to reassure mother and then tell her that some of the conditions may not require treatment also. Okay. So how to triage? So the reception and the resuscitation area of the casualty of the hospital. Ideally, casualty area of the hospital should have a newborn corner where you should keep a radiant warmer and receive such babies in the newborn corner. Okay, so all the staff should be trained in the triaging process. The most experienced doctor trained in neonatal care should take the responsibility of emergency treatment, keeping in mind the TABCD steps. So in older children, you would have thought of this ABC or ABCD, but in newborns, temperature always comes first. Maintaining normal temperature can save babies. So temperature maintenance is very important. And then airway, breathing, circulation, coma, convulsion, and dehydration. Okay, in that order, we need to think. So this figure, summarizes the common conditions with which babies can present. And when we are facing babies with emergency sign, so we need to start appropriate treatment. Okay. So we should make sure that neonate is warm. So we need to receive the baby under the warmer, give appropriate treatment for positive emergency sign, call for help, draw blood for hematocrit, glucose, calcium, and sepsis screen. Okay. So if the baby is cold to touch, even the abdomen feels cold, if it is positive, then you have to rewarm the babies. Okay. Make sure neonate is warm. And then in airway and breathing, you have to do a positive, you have to do a assessment. Okay, if the baby is gasping or apneic, and there is central cyanosis, or there is a severe respiratory distress that is more than 70 per minute with severe chest in drawing, apneic spells and grunting. So if any of the sign is positive, then you have to manage the airway. If the baby requires intubation, you need to intubate. So you have to follow NRP guidelines. Okay, give oxygen and make sure neonate is warm. So warmth has to be continued in each and every step. Circulation, if the baby is with cold extremities with capillary refill more than 3 seconds and weak and fast pulse like more than 160, if it is positive, so you have to start oxygen, continue warming keep the baby warm, insert IV line and give a bolus 10 ml per kg normal saline over 30 minutes. You can decide whether 30 minutes to 1 hour and proceed immediately to full assessment and treatment. So if the baby has coma or convulsion, okay, then you have to again take care of the airway of this baby, check and correct hypoglycemia because that is one of the commonest cause. If convulsion continue, give IV calcium. If convulsion continue, even after IV calcium, you will give anticonvulsant. If there is severe dehydration, only in cases with diarrhea, okay, diarrhea plus any two of this like lethargy, sunken eyes, very slow skin pinch, Then we have to insert IV line and begin give rapid IV boluses. That is plan C of this dehydration management. Okay. So you should check temperature. If the baby is cold to touch, you should rewarm the baby. So temperature maintenance should go side by side along with other treatment. If there are no emergency signs, look for priority signs. These neonates need prompt assessment and treatment. All of us know what are all the conditions which will need priority assessment and treatment. Non-urgent conditions also we have gone through. Okay, so let us run through some case scenarios to understand whether these cases are emergency, priority, or non-urgent. Okay. So you have a 3-day-old neonate with a birth weight of 2.4 kg is brought to SNCU with complaint of inability to feed. So temperature of the baby is 36.2. Baby is lethargic, not comatose. CRT less than 2 seconds. Hands are cold. Okay. Baby is breathing normally at around 55 per minute. Heart rate 144 per minute. So assign the category of triage based on the signs and outline the management step. So what category this baby would fall into? Anybody wants to unmute and answer? Anybody wants to answer? So this baby is priority. Why? Because this baby is a larger baby. Baby is lethargic, but the temperature is not less than 35.5. It is between 35.5 and 36.5. Right? Okay. Hands are cold, but the baby is breathing normally. Pulses are okay. There is no tachycardia. Okay. So this baby falls under a priority category. Okay. So this baby is most likely is in cold stress. Okay. So this baby needs to be provided warmth, and the appropriate treatment strategy would be to start KMC in this baby. And as the baby is lethargic, we have to look for underlying other problems also. So you should always check a capillary blood glucose in this baby and also check the saturation, and you should assess the baby for breastfeeding. Okay, so this is a priority case of baby with cold stress. Okay, so the next case is day 8 baby 2.6 kg presents with fast breathing and inability to feed. So baby is not able to feed. Temperature is 36 degrees Celsius. Okay, respiratory rate is 74 per minute with significant lower chest indrawing. Heart rate is 156 per minute. Capillary refill time is 4 seconds with cold extremities, poor periphery pulses, but there is no diarrhea. So what is the category? So this is emergency category. Yes, Dr. Simran has answered. Yes, it is emergency category. Okay. So what are we supposed to do? Why it is emergency? Because there is shock, there is severe respiratory distress. So this baby needs immediate treatment. So you have to maintain the airway of the baby. You have to start oxygen immediately. Okay, either by nasal prongs, or if you have facility to start, other HFNC or other humidified ways of providing oxygen, that would be preferable. Start monitoring oxygen saturation. You can consider HFNC or CPAP. Okay, so if you think baby needs intubation, baby may require intubation also. Okay, so you have to monitor the vitals and the severity of respiratory distress. You have to establish an IV line and give a normal saline 10 ml per kg over 30 minutes. Okay, if the pulses are very weak, you may have to give a faster bolus also. So you have to do assessment, consider starting vasopressor, and identify the underlying cause and treat it. Okay, that is also important. A neonate with respiratory distress can have underlying pneumothorax also. Once you drain the pneumothorax, shock also may improve. Okay, so not all respiratory distress are due to sepsis or pneumonia. We should not be thinking that it is just due to sepsis and keep on giving boluses. okay, without even resorting to clinical examination for reduced air entry or taking an X-ray and ruling out pneumothorax. Okay, always you should after establishing yeah, after initiating the emergency treatment, you should always look for the cause and go for a specific treatment. That is always important. So third case is 15-day-old baby with the 2.9 kg is brought to SNCU with fever and abnormal movements for 2 days. Okay, temperature is 38. Okay, heart rate is 110 per minute. Respiratory rate 65 per minute. Respiratory rate is 65 minute with no chest in drawing. Capillary refill is 4 seconds. Extremities are warm, but baby was convulsing. So what are what is the category here? Any baby with convulsions coma is considered as you know emergency. Okay, so here again we have to go through TABCD. So temperature of this baby is 38 degrees Celsius. So baby is not hypothermic. In fact, baby is hyperthermic. Okay. In airway, you have to look for secretions, maintain neutral position, shoulder roll. So start oxygen if for the baby, titrate the oxygen saturation. Access the establish the IV line, and then you have to check capillary sugar. So if the glucose is low, you have to correct that, and then you may have to test for serum calcium, and if the convulsion persists, you may have to continue. I mean, you may have to administer anticonvulsants, and you have to go for other assessments. Like this baby here is hyperthermic, and baby is presenting with seizures. So a hyperthermic baby could be dehydrated. Seizures can be due to some electrolyte abnormalities. So all these things you have to take into consideration and go for assessment for the underlying cause and treat. Okay, right. So in pediatric cases, you would have you must be familiar with this AVPU scale also. A neonate who is not alert and active but responds to only voice is lethargic. Okay, so an unconscious neonate may not respond to pain. Okay, so a neonate with the coma scale of PRU, that is unresponsive or responds only to pain, is emergency. A baby who is who responds to voice is considered lethargic and could be a priority case. Okay, an alert baby is a non-emergency case. Okay. So 3-day-old baby weighing 4.5 kg brought with a refusal of feed. Okay, bleeding from umbilicus. So this baby on examination has a temperature of 37 degrees Celsius, heart rate is 144, respiratory rate 150 per minute, CFT is normal, icterus up to mid-thigh. So how will you triage this baby? So this baby, what are the signs? There are some priority signs. That is, baby is refusing to feed. Okay, so that is a priority sign. There is bleeding from umbilicus, so we need to evaluate and treat. But the baby is not in shock, not having shock. Okay, so what about jaundice in this baby? It is only up to mid-thigh, so it is not an emergency sign. It is not a priority sign also. It is in fact non-urgent because this baby is a older baby and it is up to only mid-thigh. Okay. So refusal to feed needs holistic approach and adequate assessment. So the cause for refusal to feed may vary, right? So we need to identify the underlying cause. So this baby is a priority baby. You need to identify why there is refusal to feed and you have to treat it by identifying the underlying cause. But umbilical bleeding may be due to vitamin K deficiency bleeding. You need to go into the history, and if vitamin K was not given, you may have to administer vitamin K to the baby, but you need to admit the baby for observation and to assess the treatment, whether the response to treatment. Okay, so thank you. So if there are any question, then you can put it in the chat box. I can clarify, or you can unmute and ask. So there is one question from Tangadurai. Why in JR preparation we have to add distilled water? So GR preparation, sometimes we may add distilled water because to achieve the right dextrose concentration and GIR. For example, you are using a combination of 10D and 25D, or 10D and 5D, 50D, okay, in dextrose. Then if you are not able to get the right percentage, right GAR, then you may have to use distilled water to bring the GAR to the required number. Okay, so sometimes, very rarely, we may have to use that when there is some fluid constraints. We are not able to use 25 and 10D as combination. Sometimes 50% extras plus some distilled water might be used rarely. Okay. Evidence of tablet nifedipine for persistent hypoglycemia. I am not aware of any use of nifedipine for persistent hypoglycemia. Persistent hypoglycemia, you have to identify the underlying cause. Usually it is hyperinsulinism or coexisting endocrine or metabolic problem, which needs to be identified and treated. Okay. I am not aware of nifedipine being used for persistent hypoglycemia. Any other question?
Hello.
Hello. Yeah. Yeah. Go ahead, please. May I know who is speaking?
Sir, yes, sir.
Yeah, Tangadurai, please go ahead.
Tangadurai, Sir,
Yeah, go
in
ahead.
our
Go ahead.
unit, we are preparing GR with 25D along with Optinus or sir, can you hear me? Hello?
Yeah, I can hear you. Please go ahead. Yes.
Yes, sir. In our unit, we are preparing GR with 25D with Optinus or ISOP only, sir. It's like a 25D with 5D.
Okay.
So we are not adding any NS or a distilled water. That is what you
Okay.
posted that how to mixing the calculation. It is a standard one or it is where it's published, sir? Which unit protocol? This is our your unit or standardized one? Yes, in the clarity also they didn't mention about any this, like they also given the formula only to add how to make a 25D with add to 5D only. They are not mentioning about a 10D or a slow order. They are given one word, normal sense should be added like a 10 ml per kg.
See, you can use only 10% dextrose and 25% dextrose if you don't have to use electrolytes for the baby, right? Especially in first 24 to 48 hours when we don't want to use any sodium or potassium, you can use that. Okay. So on day 3,
Okay.
day 4, when you want to give sodium, that time you can use DNS instead of your plain dextrose. Okay. So it depends on on what day of treatment you are initiating the fluids. Okay. So there is no fixed a recipe that you should not be using 5% dextrose. You should be using only 10% dextrose, or you should not be using 50% dextrose. So in babies who are very small babies who are in whom we need to restrict fluids, we have even used 50% dextrose to achieve adequate GAR. Okay. So it is standard recommended everywhere. Okay.
Okay. So, the chart is prepared.
The chart is only a reference.
It is a published one.
Chart, the reference chart, whatever is used is a standard one. Okay. If it's to suits your unit, definitely you can follow that, or whatever is working for you. If you are comfortable with that, you can continue with that. No problem. Okay.
Okay. So one more dot, sir. See, we are having one more baby. That is diagnosed as hyperinsulinic hypoglycemia, which is requiring injection of
Okay.
and hydrocortisone and the dioxide. Even that there's a hypoglycemia, recurrent hypoglycemia was there. How do, because baby already crossed 2 months, 60 days. Still we are continuing injection octreotide, disoxide, and nifedipine is started on this, sir.
Okay.
So how to overcome even
this baby?
octreotide?
So I personally, I have not used nifedipine, but yes, diazoxide and octreotide we have used. But with these two agents also, if we are not able to maintain glucose, then we have tried glucagon infusions also in subcutaneous infusions in these babies. So with all these measures, if we are not able to maintain adequate sugars, then it is a severe form of hyperinsulinism, which needs further treatment. So this baby needs imaging to identify whether this baby has a focal or diffuse, islet cell hyperplasia. So this baby will need a DOTA-NAC scan to identify whether it is a diffuse or focal islet cell hyperplasia. If it is focal, they respond very well to surgical treatment. If it is diffuse islet cell hyperplasia, then surgery is very difficult. So some of these babies have responded to sirolimus. That drug has been found to be useful in reducing insulin secretion. And personally, I have used in one baby, and this baby has shown very good results. Okay. So if they are not responding to sirolimus also, then they may go in for a subtotal or near total pancreatectomy along with sirolimus. Okay. So these are all some of the treatment modalities which are available. So they have to undergo a DOTA-NAC scan, DOTA PET scan, to identify whether there is islet cell hyperplasia, and they may also require an exome sequencing to identify any genetic mutations, usually called as SUR and KAR6 mutations, which will be the underlying cause in such hyperinsulinemic hypoglycemias. Okay, so they need further evaluation and treatment if they are not responding to these medical measures.
Okay, thank you, sir.
Okay, yeah. Any other questions? Where are you from, Dr. Tangadurai?
Sir, I am from Madurai, sir, Tamil Nadu.
Madurai Medical College.
Madurai Medical College.
Okay, fine. Okay. So any other questions? So no other questions. I think if there are any no more questions, we will wind up. I think I didn't introduce myself. I am Dr. Chandrakumar Natarajan. I am a senior consultant and head of the department of neonatology in Kanchi Kamakoti Child Trust Hospital, Chennai. Okay. So thanks for listening to me, and thanks for all the interactions. Hope you had some insight into hypoglycemia and ETAT. Okay. Thank you all. Shreyasi, can you stop recording? Hello. Hello.